Welcome, everyone. Rush University Medical Center, Division of Nephrology, Renal Biopsy Conference for October 23, 2025. We've got a fun case today. It's kind of complicated. It's going to go a while, so I'm going to start moving along here. This is Dr. Whittier's and Dr. Baxey's case. Dr. Corbett is in Paris still, so I think we're going to rely a lot on Dr. Gashti to discuss the case for us. We maintain patient privacy and we have nothing to disclose. I want to wish everybody a happy Diwali. I see some smiles, that's good. And I think I'll hand over the protocol to Dr. Thurmani, our first year fellow. Raj, you want to take over?
Yes, I got it. Good afternoon, everybody. So this is patient who is a 43-year-old Hispanic who's got a history of Oh, also, before I start, I have a speech impediment and I stutter, so just go along with it. Hypertension, cocaine and alcohol use, type A dissection of the aorta, complicated by cardiac tamponade, and he had a root surgery done with a valve conduit. He also had a 26-millimeter graft as well. He came to the hospital because of a high creatinine and abnormal UA. Nephrology was, of course, consulted for an AKI and hematuria that was gross. He had been experiencing abdominal pain and hematuria now for about 3 weeks or so. The patient reports that his last cocaine use was 2 years ago, and his last alcohol was 3 months ago. He did have a sore throat 1 month before he started to have hematuria. He denies any again said use. His baseline from a month ago was under 1. Past history, as I've already talked about the heart and the hypertension and this substance abuse. Past surgical history, the replacement of the aorta. He didn't have any family history, and medications involve Coreg, amlodipine, and lisinopril. Physical exam was essentially benign, except for the cardiac murmur, which was not new. The labs were pertinent for creatinine upon admission was 3.5 with a BUN of 45. Hemoglobin was 9.8. Platelets were 242. His percent saturation was 16 with a ferritin of 951. Haptoglobin, and LDH and hepatitis and HIV were all not remarkable. ANA was negative as well. Complements. C3 was 112 with C4 being 35. The MPO PR3 was above 8, sorry. Then the MPO and GBM and serum immunofixation were all unremarkable. K to L ratio was 0.9. The UA showed, UA was red with 3+ protein and 2+ on the blood, negative for ketones and glucose. The RBCs were 560 with WBC being 28. The UACR was 1.1 and the UPCR was 1.5. UDS and urine levamisole were also negative. We did some imaging, of course. The ultrasound, it just showed renal disease without any findings of obstruction. The right kidney was 11.2 and the left was 13.1. He did not have any evidence of renal stenosis. CT scan was done. It did not show any dissection. The graft is in place and a TEE had no vegetations. At this point, we did a renal biopsy.
Any questions? Okay, well, we're going to start with a poll. What do you think this patient has? Do you think this patient has, number one, IgA nephropathy, HSP, IgA vasculitis spectrum? Do you think this is a pauciimmune GN, maybe levamisole or idiopathic related? Do you think this patient has ATN? Do you think this patient has post-streptococcal glomerulonephritis? Or do you think this patient has something else? Let's get some votes in. We can't see what your vote is. Let people vote. We've got about 60% voting. Yeah, I know you can vote. A few more, maybe. Now we're getting closer. Okay. That's good. 75% voted. So the number one is pauciimmune, either levamisole or idiopathic. Number two is the IgA-related disorder. ATN gets 1 vote, post-strep gets 3, and other gets 3. I want to hand it over to Dr. Gashti. What do you think? Casey? We'll leave the poll up so you can kind of discuss each of these, your thoughts why they were put up and what do you think's going on?
Yeah, so basically this is a patient who shows up with acute kidney injury, and F3 is what's kind of like stands out from a serologic standpoint. He does have hematuria, so it's got an active urinary sediment with about 1.5 grams of proteinuria. So what stands out from just going from the top of the poll to the bottom, IgA nephropathy is possible. But obviously the PR3 being so positive, it really sways me more towards having a vasculitic picture as opposed to an IgA, which should, at least for the most part, have a negative ANCA. Pauciimmune glomerulonephritis, aka like a vasculitis, because the patient has a polysubstance abuse history, that comes to mind, specifically the presence of levamisole. So I'm glad there was a negative urinary levamisole screen. That kind of depends on if the patient was sort of recently used or had previously used this. So the timing of drug use versus the test kind of comes in to play as far as that levamisole being negative. However, if the patient had used levamisole in the past, this is still a possibility, or the patient could just have a non-levamisole related ANCA-associated vasculitis. I don't think ATN would be, ATN is always on a differential in AKI. People can have ATN along with other things, but I think with that degree of active urinary sediment, PR3 being positive, and this is a biopsy conference, I think all those factors will lead me away from just ATN as the explanation for the AKI. Post-streptococcal GN, the complements, if I recall, were normal. Usually we have hypocomplementemia in post-strep. So although that's not entirely impossible, I would think that that's less likely because of the presence of normal complements. So I'm going to go with 2, that this would be a glomerulonephritis, non-IgA, and it would be because of the PR3. I would think this would be more of a GPA looking picture.
Yeah, I wonder what percent of people, just the general population, have a positive PR3. Because, you know, when you look at this, he's Hispanic, he's got abdominal pain, he's got very active urine. And, you know, I suppose that's why about a third of the people thought it was IgA. And I don't really know. I know certainly ANCAs aren't rare, but I don't know the sensitivity of a PR3.
In gross hematuria too, it's, I mean, it could be seen with ANCA vasculitis for sure, but we think about gross hematuria a lot more with IgA.
No, thanks, Bill. Yeah, you're right. That, and you know, that's where the post-strep comes in too, I think. Dr. Reen, you had a question?
I think I will look into other also. He's a Hispanic. He could have LAC2 amyloidosis, and there are few cases described with the ANCA positivity. They may not have post-immune glomerulonephritis per se, but when they are combined, whatever 3-4 reports are there, they actually have very aggressive kidney disease.
You think they're related or just 2 independent things?
I think I will leave that to my presentation when I do my next rounds. That's what we discuss.
Way to give it away.
All right.
No, I was going to give it away anyway.
I think I agree with Bill that IgA is fairly attractive here with gross hematuria following an upper respiratory infection. Probably non-streptococcal because the C3 is normal. And I'm intrigued by the suggestion of lambda predominance. You know that the circulating IgA in patients with HSP and IgA nephropathy is lambda dominant. This is not an abnormal ratio, but you know, it's on the lower end. And I'm just curious to whether he has a circulating lambda dominant IgA. Certainly the hematuria can produce AKI as a result of the red cells in the lumen. I assume he's not on anticoagulants. If he were, I would raise the notion of an anticoagulant-induced nephropathy way up in the differential.
Yeah,
Why
that is
not?
correct.
Why
He's not
not?
on.
What? He's not
No,
on
you are.
anticoagulants.
They are correct. No anticoagulation.
Yeah. Of course, we can't rule out posse immune, but it would be ANCA negative. Oh, I see his PR3 is greatly elevated. Oh,
Yeah.
okay. I'm sorry, I missed that. All right. Well, that's a very important clue. I would like to see the rheumatoid factor, even though his TEE is negative. It still has a false negative rate of about 10%. And you know that we have had earlier cases with endocarditis that had no abnormal TEEs. So I don't think we could rule out an infection-related posse-immune GN in this case. Not at this point.
Yeah, rheumatoid factor was not done. So we're not hiding, we're not keeping anything from you, but it was not done, so.
Yeah.
So, any other thoughts, anybody? Arun, what do you think's going on?
I think they've all summarized it pretty well. The only thing was the IgA is a good consideration, but it's usually synpharyngitic. It occurs concomitantly. There is a lag of 1 month, but again, that depends on the kind of infection. The other things about the infection and indolent infection, especially with a graft, we also have to worry about some of the fastidious organisms that don't grow, like Coxiella and the Hayseck organisms. But you know, and pure PR3 ANCA, but without just renal limited PR3 without other systemic features, we don't have, you know, it's a little atypical for PR3 to just present with isolated renal. I think he was somewhere, he's young, he's 30. And just throwing another differential, which we didn't speak about, is what about a crescentic C3GN? I mean, he's got an infection. He comes in 1 month later. I mean, we don't always have to have low complement. So I'm also concerned about that. But I'm really worried about a crescentic necrotizing GN.
All good points. Next slide. So I think we'll get to the biopsy here. My God, it's terribly off. Okay, great. Spin the wheel. We don't have many people available here, but so we might have just picked somebody, but we'll see what the wheel says. Oh, looks like it's me. Okay.
Oh, that's unusual.
Yeah, Dr. Glassick, you're right. It's unusual because guess who spins the wheel every week?
Yes, I know.
I mean, it would never fall on me either if I'm the one spinning the wheel.
Guess who has the magnet? All right.
Oh, you're jumping too fast.
Well, yeah, I only clicked once. All right, we have a core. Doesn't look trichromy to me, but that's usually what you do.
Got some blue.
Yeah, I suppose. I'm color challenged, if you remember. I was hide behind that, but anyway, it doesn't look very good. I don't see it. You know, I see a lot of gloms, but you can't really tell that how they look here. They don't look very good. And the tubules, again, there's a lot of spacing. I think we just move on, but it doesn't look very normal to me. Okay, this is shows 2 gloms as an H&E. Lot of interstitial inflammation, a lot of looks like lymphocytes surrounding this whole area, but I see 3 glomeruli there. None of them look very normal. You don't see open capillary loops. It's chock full of cells. And I think we'll go to a higher power, but you know.
Well, yeah, one of them has bright pink pockets of fibrinoid necrosis.
All right, well.
And there's some crescents starting to form, so.
We'll
Okay.
see that on a higher power.
Okay.
Thanks for calling me out on that, David. I really appreciate that. That's, you know. I know
going too fast. Hold
I've
on.
got the wrong. I know that is me, by the way.
Okay, hold on. Let me. Go
Yeah,
back.
it's my mouse skips with just the weirdest things. So I got
Hold
a
on.
different mouse now. So I think I can do it if you put it back.
Okay, give me a second.
It's an
I
odd
want people to see the
Apple mouse
diagnosis.
thing.
There we go.
All right.
I'll give you control. Give me a second here. All right, go ahead. Yep.
Okay, so here you can see what David was describing. Here's the pink in the middle, which looks like fibrinoid, and I think this is a crescent surrounding here. And also, is this a glom down here as well, David?
Those are tubules.
That's a tubule. Well, then it's just full of.
Yeah.
stuff.
But there's a Highland cast in the one.
Okay. Oh yeah, but here this glom is not in good shape, and I think there might even be some Caryorhexis and maybe a poly or two here.
Yep. Yeah, we can't even see the tuft. It's all crescent
Yeah.
necrosis.
This is a PAS, and here you get a better idea of the architecture here with the crescent on the right, being a segmental lesion. This glom actually does have some open capillary loops, but it gives you a better idea of the general architecture. Moving up, this glom is really destroyed with a lot of fibrinoid necrosis here, and these loops here look really quite thick. So I don't know.
I think those are epithelial cells that are proliferating. Yeah.
Oh, really?
Yeah.
You know, I would wonder about an MPGN or I mean, what about here? What about this? Isn't this like a large wire loop here? Or is that just more?
No, I think that's part of the necrotic area.
Well, let's point out I'm like 1 for 5
Yeah,
so far.
because over at 6 o'clock to 3 o'clock, you could see, relatively preserved tuft down there.
Okay.
Yeah.
This is a silver, high power silver, and I think it's a little overexposed, but what you can see here is, pieces of basement membrane kind of flying out. So I think this just is meant to represent the necrosis, the segmental necrosis. And I suspect some of these cells over here is the crescent.
Yep.
No corrections on that one, David? I'm making
No,
progress.
you're doing great.
No, I think he's just being, I think he's just being nice.
He's being nice. That's fair. That's fair. This is another PAS, I believe.
Yep.
This glom doesn't look quite as bad. Looking at the, I don't really see a segmental lesion there. The brush border looks pretty good here on at least most of these tubules. Here's a little bit of maybe ATN here.
Yeah, lots of brush border, and then the tubule over at the bottom right, you could see the sloughed right there, sloughed epithelium.
Yeah, that's what I think. Yeah.
Yeah.
So some
So
ATN.
in the background, there was no proliferative GN here. You could see the few uninvolved glomeruli that weren't necrotic had preserved architecture.
Mm-hmm. So here is IgG, IgA, and IgM, which is not negative. It's kind of a full house but a mesangial pattern. You can see it there. So thinking about IgA nephropathy, this would fit, but I don't think you'd see all three of these with, or rather IgA here, and this is IgG here and IgM. I think that's a little much for IgA nephropathy. So, pauciimmune is, it's a relative term. I know when we talk about lupus, we will see mesangial deposits, and we don't consider them to be a big part of the disease. And so when we see, we will often call this pauciimmune lupus with full house, even though there are immune aggregates here. When we refer to the aggregates, we really talk about them in the capillary loop. So, I mean, it's a matter of semantics or nomenclature, but this is definitely mesangial full house staining, which moves us a little bit away from some of this. I don't know. So I'm just going to describe what I saw. We saw crescentic GN with some ATN, some interstitial nephritis, and mesangial diffuse mesangial deposition of IgG, IgA, and IgM.
Yeah, and C3 was co-equal as well.
And C3 was co-equal as well, and that.
Because if there was, I think Aruna brought up C3 nephropathy. If the C3 was, 2 or 3 times more than these, then you might think about C3GN as well. So co-equal C3 is my point.
So next slide. So before we talk about what, we really think, based on the biopsy, I want to poll people, and then we're going to hand it back to Dr. Gashti about how he would answer this. But how would you treat this patient based on what you saw? In addition to corticosteroids, would you give a cyclophosphamide-based regimen? Would you give a rituximab-based regimen? Or would you give a rituximab-based regimen with daily oral cyclophosphamide, which has been described non-prospectively by Mass General, or MMF? I'm going to stop there. I think it's interesting because, rituximab has kind of taken over treatment for a lot of things, but certainly often a primary treatment for vasculitis. Yet cyclophosphamide won in both of, either cyclophosphamide alone or cyclophosphamide with rituximab were the two winners here. But it was pretty well spread amongst all of these with a little bit of MMF. I want to hand it back to Dr. Gashti. Can you kind of interpret the biopsy? Well, how do you make this together with the clinical scenario, and how would you treat this patient?
So, yeah, I mean, as you mentioned, this was a crescentic, quite proliferative glomerulonephritis, and it was for the sake of pathophysiology, I feel like this was pauciimmune because all the staining that I saw was mesangial and wasn't really much in the peripheral capillary loop area. So I would consider this I don't know why the mesangium stained that much for all of those immunoglobulins, but I think the nature of the damage was pauciimmune. So I would treat this like vasculitis. So I think if you add 2 and 3 here, the vast majority of people agree, like I think 60-70% of people would do a rituximab-based regimen. And that's what I would do. I'm not sure how much of this AKI is that ATN or how much of it is the GN, but this is a pretty bad GN. I would tend to go with number 3, just so that, you know, if I have one chance of putting this in remission, I would take that.
So just to remind people that their regimen is rituximab, but they give a couple months of oral cyclophosphamide. The first week, I believe, is 2 milligrams per kilogram, or 2.5, I think, and then they go to 1.5 after that for 2 months, and give oral prednisone as well, with a fairly decent, you know, with a fairly rapid taper.
I have a feeling this is going to be one of those situations where you have to figure out if the patient with the history of drug use, if the patient is going to follow up. So I think there's going to be some social aspects of care that, you know, may play in. So if those come in, then maybe a rituximab-based regimen would be better, because you just give the IV and you see them, you know, 2 weeks and then 6 months, as opposed to having to do CBCs weekly because of the oral cyclophosphamide and all the other issues. So I think some of this decision may come to that.
It's a good point. And not only that, just, you know, taking the cyclophosphamide, you know, rituximab is a thing that you can, you know, you see it in the IV, and then it's gone. You know, it's gone. You know, it's been administered. Pravir, you had a question or a comment?
No, it was an accidentally hand raised.
Okay.
I don't know why a hand keeps on getting raised.
Roger,
Raised again. I have no questions.
I'm a little surprised at how quickly people jumped on the immunosuppression bandwagon. Here's a patient with a heavy background of endocarditis who has a positive PR3, a lot of IgM and IgG in the biopsy. And how do we know that this is not infection-related GN?
I don't know that we know that, but Bill, wasn't this like 3 years after the aortic valve?
Yeah, so exactly. So yeah, his valve in basically entire aorta was replaced 3 years ago. All we do know, Dr. Glassick, is that blood cultures were negative. But yes, to your point, the fastidious organisms were not checked. And
If
somebody
I
just in the
may-
chat. Oh, go ahead. Sorry, Mario.
No, I'm sorry to interrupt you. Please finish.
I think somebody in the chat maybe also said that, yes, the ANA was negative as well, and the complements were normal.
And what about the rheumatoid factor?
It was not drawn.
So what I was going to say is that today I participated at the biopsy conference at Columbia, and interestingly,
Oh my God, are you cheating on us?
yeah, well, listen, I get all the teaching I can get. Anyway, and they, as we all know, had the initial series. The senior author was Viveta Gatti on post-infectious GN. And that series, plus a consequent series from Arcana and a recent series from the Cleveland Clinic, point out that on the biopsy, there is predominance of C3, which we didn't see here in cases of post-infectious GN, and it's always present. In addition, in the majority of the cases, there was a low C3, so which is not in keeping what this patient is showing. That's a comment that I wanted to make because I learned something.
Dr. Glassick,
I wrote a paper a number of years ago about the use of the term post-infectious. Post-infectious means the patient isn't infected at the time the biopsy is done. This is an immunological consequence of a prior infection. What we're talking about in this patient is an active, ongoing infection. So the term post-infectious is completely irrelevant in this case. The term infection-related GN, I think, is a much better way to define how we view the role of infection in this patient. I would agree completely what Mario says. C3 dominance, low C3, a latent period between the infection and the onset of GN would be expected in post-infectious GN.
Now, Dr. Glassock, to remind you of something that a stellar individual by the name of Richard Glassock recently stated in the forum was, you can call it whatever you want. The end result is the same, unquote.
Yeah.
What about this biopsy makes you think of infection?
IgM prominence in the mesangial deposits, a PR3 positivity in a prior drug addict with a artificial valve, with an aortic valve, and the absence of any knowledge about his rheumatoid factor.
The other thing that we did not comment upon that the biopsy showed, which we brought up last week, was there were lesions in the glomeruli of different stages. There were fibrocellular as well as cellular crescents, which are in keeping with the vasculitis type of process.
Yep.
Okie dokie. Next slide.
All right, so a little update here. This was actually a case from an outside hospital from 2 years ago. And they diagnosed him as levamisole-induced vasculitis. Even though, again, the urine drug screen was negative, levamisole was negative, and Dr. Gashti talked about the issues with that. So what they elected to do is treat him with, making sure that he didn't use cocaine anymore. And they gave him prednisone, IV Solu-Medrol. They gave him oral prednisone, and they gave him rituximab. He was compliant with these infusions and with his prednisone and prednisone taper. He maintained his rituximab at every 6 month intervals. Some history in the last 2 years is that he confirmed on history that he had stopped cocaine. His creatinine improved to 1.2. His hematuria never went away. His proteinuria was usually around 800 milligrams or so. His MPO and PR3 became negative, and his urine drug screens all remained negative. Next slide. There may have been something at the bottom there. But Raj put this, what is it called, a meme or a GIF or something like that? I don't know what the kids call it nowadays, but this is great, because 2 years later, after he'd been with Rituxan the whole time, this picture's worth 1,000 words. This is kind of how he came to us. Very sad. He developed thrombocytopenia and microangiopathic hemolytic anemia with a high LDH, undetectable haptoglobin, and it was Coombs negative. Remember, 5 years ago now, he had this entire aorta replaced and valve. Well, in 2025, just 3 months before we met him, he actually had to have his entire aortic valve replaced for severe aortic stenosis with mitral regurg. And then this was also the 5 years after his initial surgery, but it was 2 years after he had started his Rituxan. Okay, so 6 months after that, he's developed this microangiopathic hemolytic anemia, needed his valve completely replaced, so a redo prosthetic valve. And he now comes into Rush for AKI. His last Rituxan was 2 weeks prior to his admission. He said, again, no cocaine, I'm not doing it. His creatinine was 6.9 on admission, urine active. His urine PC was 8.2 grams. His CD19 count was 0, confirming his recent Rituxan. His PR3 was now negative, and his MPO was now positive. On his arrival to Rush, he had a fever of 103, but otherwise was hemodynamically stable, and he had dark urine. On exam, he basically had a murmur that was unchanged. His temp was 103, and we can go to the next slide. And here's his labs. Creatinine was now up to 9.3, and we were setting him up to get dialysis. His hemoglobin was 7.5. So the and his schistocytes are positive, haptoglobin undetectable, LDH is all high, consistent with his MAHA. And that was still about maybe, 4 months after his valve replacement. Okay, Coombs was negative. His ADAMTS was normal, and his CD19 count was undetectable. ANA and double-stranded DNA is still negative. Now, though, hypocomplementemia, C3 of 54. His rheumatoid factor, first time it was checked at Rush, was 45. elevated. His cryo was negative. His PR3 was negative. His MPO was positive, and his sed rate and CRP are there. His urinalysis remained active. His urine drug screen was negative. Blood cultures and urine cultures were negative. Chest x-ray was negative. His renal ultrasound was no different. His CAT scan showed that his aorta was in place. His valve looked good. We did a transthoracic and then a transesophageal echo, which essentially was pristine with the exception of some prominent calcification on one of the anterior leaflets, but there was no thrombus, no leaks, no rocking motion, no dehiscence, no regurgitation, and that is it. A question in the chat, did they culture the valve? The answer is no. They just replaced it, and we met him now, put him on dialysis, and got a biopsy.
Now, Bill, I don't understand. The TE says the all valves are normal, but he had a whopping regurgitation murmur.
Let's see. I know that, let's see. Well, I was meeting him for the first time. Cardiology had been following him the whole time, and they had reported in their notes that there was still a murmur there. But the TE, you're right, the TE was, and yeah, the TE and TE were both essentially normal, except for this calcification. And possibly, I mean, his aorta was replaced, so they might have been hearing a flow, through that.
Yeah, I don't know. Whenever I hear the term holosystolic murmur from the good old days, I still think of mitral regurg. Anyway, so be it.
I mean, maybe it's like I'm not sure, but thank you for bringing that up.
Next. So what do you think this patient now has? A post-immune crescentic GN, immune complex crescentic GN, a TMA, or 1 and 3, which is a TMA with post-immune crescentic GN, or immune complex crescentic GN with a TMA, or something else? Go ahead and vote. Is the poll open? There we go. Poll is open. Sorry. That's probably good enough. So our top vote getter is 2 and 3, which is immune complex crescentic GN with TMA. The second is a post-immune crescentic GN with TMA. TMA by itself didn't get many votes, and other didn't get a lot of votes. And nobody was with post-immune crescentic GN by itself. Next slide. Casey, what do you think's going on now?
I think now with the low complements and all the new findings, I do believe this is immune complex. And I don't know, there's a discrepancy between what the echo shows, the patient, now it seems like maybe endocarditis, it should have been on the differential from the get-go, but I think now it should definitely be on the differential, especially with this, all the immune complex mediated, sort of like the low complements, the rheumatoid factor, the hemolytic anemia, the murmur, in somebody with all of this cardiac surgery. I still think that the post-immune is less likely at this point. I think maybe immune complex mediated, and where is the immune complex coming from? I have to believe somewhere in the valve.
And anybody else have any other thoughts?
Roger, the other thing I was going to say was, this anchor is not a primary anchor because initially it's PR3, it's switching to MPO, and there is a explanation from the Boyle's paper that, an infection, an atypical infection can trigger these anchors. And so that's why I think we're switching it from PR3 and now to an MPO. So I would really make sure that this patient does not have an infection.
You say infection is more likely to switch, or just association of the ANCA?
No association with the ANCA, because if it
Yeah.
is truly an ANCA positive process, why would it go from a PR3 to now to an MPO? It's only when it's non-selectively activated, and most likely these cases are underlying infections.
Interesting.
Now, Arun, Helmut Reinke will call that the antigenic spreading phenomenon, and which is in part goes along with what you're saying.
Mario, could you just elaborate on that? I didn't.
Well, basically, the epitope that triggers the immune response changes. And as a result, there is a different type of immune response with ends up with a different immunologic specificity.
Mm-hmm. Interesting.
What other infectious workup would you do, Arun? Like just some of these less, cultures or what?
So the one thing that did catch my eye was the initial biopsy was IgM positive. At least to me, it looked more. And one thing we always have to look out for is Bartonella henselae, which causes this. And Bartonella does not grow in blood. So you really have to do PCR testing for Bartonella.
Fair enough. So let's look at the second biopsy. We'll tell you that it was I think we have one glomerulus. And I'll kind of describe it. It looks a little. It's very. There's a lot of cells in there. Let me just say that. I don't know. I don't see a crescent. I don't see the segmental necrosis we saw. I do see at like 3 o'clock what looks like a wire loop down here. A little further. Yeah, I think that looks like a wire loop. It's a lot of mesangial proliferation. I wouldn't call it segmental proliferation. What I don't see is a creatinine of 6 or 7, which is what the patient has AKI now. I would have predicted that more with the first biopsy than this one. And I know we have a single glomerulus, is what I believe, or maybe 1 or 2. So we're just stuck with what we have. Next slide.
Roger, there is endocapillary proliferation as well. Some of the capillary lumens are occluded by cells. If you move your arrow, keep going upwards and down now, down, 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 down. Anyway, there are some capillary loops there that are filled with something which is probably polis, I guess.
PAS, again, architecture is much better than most anything we saw in the first biopsy. Mostly looks like a mesangial.
Is there any double contour at 6 o'clock?
Lots of double contours.
Well, down here you can see a double contour. Here you could I don't think my arrow is showing, so it's Previre's, but.
Well, it's a lot of double contours.
Yeah.
In this biopsy.
So
you look right at 1 o'clock. There's a really nice one.
You're
right there. Yeah, beautiful.
Pattern of injury.
Yeah. And I think the hilum is down at the bottom, so I don't think that's a.
So actually, that's a synechiae there because I think the hilum's at 10. Yeah.
Oh, okay.
Go up to 10 o'clock. Yeah, because you could see.
Okay, there's the hilum. So that's
that's the
hilum. Yeah. Okay, that's an adhesion. Okay.
Yeah.
And then the silver again looks overexposed. You don't really. I don't know. They look thick, but I don't know what to say of that. I don't see the obvious double contours here.
I think it was overexposed. Can't
really say much there.
Yeah.
So the diagnosis is what looks like a proliferative glomerulonephritis. We don't have IF. We don't have IF to see, but suggestions of immune complexes by the double contours and what looks like wire loops. I think I'm going to hand it back to Casey for a third time. Wait, let's see. Do we have a poll here or not?
It's just Bill slides.
Are we going to Bill? Okay. Yeah, it's a good time. Go to Bill.
Go ahead, Bill. You can control the screen. Where do you go? Uh-oh.
You there, Bill?
There we go.
There we go. Go ahead, click on the
I'll
screen.
explain this in a little bit here, but this is POSSE, which is in quotes, immune GN, encovasculitis, and this is another pattern of injury, and I'm going to talk about that in a second here. And so let me just give you some follow-up with what happened. The renal biopsy, unfortunately, the reason there was only one glom is because they had to stop immediately after the first pass. There was massive bleeding, required embolization. We didn't even get immunofluorescence on the tissue. So we're sort of left with this, what we think now is an immune complex mediated GN based on the light. We don't know which type of immune complexes, but we have the biopsy from before, fortunately. He required dialysis. His fever initially on presentation was there. He defervesced initially, but then he started having fevers again afterwards. So when we saw him, even though his echo was completely negative, his routine blood cultures were negative, we asked ID to come by, and we also sent off the culture negative endocarditis workup. And when we consulted infectious disease, I think some of them may be on, but I think laughing at us might have been the appropriate thing from what I saw of their rounds, meaning how can you talk about endocarditis when there's no endocarditis? And how can you think about this when what would make you think about that? And so so we had kind of sent it off, but I wanted to make sure that at least the culture negative endocarditis workup that we sent off was complete. And that's why we had done that. So reluctantly, it was sent off. And lo and behold, just as many in the audience have guessed, the Bartonella Hensley titer came back positive, and the Bartonella PCR was detected. So what I wanted to kind of talk about is that this is our classic encovasculitis. Immune complex negative, crescentic. You probably see some fibrinoid necrosis here, and you'll see fibrin on the IF. But normally this is completely POSSE immune. I want to give you a couple other scenarios here. These are all from published findings in the literature. And I would tell you here that they are all identical in a way. Crescent here, background mesangial. Segmental necrotizing lesion here, background mesangial. Crescent here, background mesangial. You get the idea? Crescent here, background mesangial. Same pattern of injury. Guess what? Anybody want to guess what the cause is in number one? You would have no idea, really. But I'll tell you, that one was hydralazine. This one I'm sure you should all recognize because it's our publication. That's what lupus is. That's what we like to call lupus class 3. This is the one that Dr. Glassick just said, endocarditis. And this one is from levamisole. Okay, so all of these have this commonality of what looks to be on light microscopy, this encovasculitis, segmental necrosis, crescents everywhere, but the background mesangial and possibly even a full house pattern along with fibrin, which is again different from what we were talking about in the previous one. Okay, so then those are the references. So there's some ways that we could try to figure this out. For example, I think C1q is a lot more predominant if it's levamisole. We talked about how C3 might be more predominant in some of the endocarditis or in the infection-related ones. I think Arun had also mentioned that, what did he say? IgM was more predominant in the Bartonella ones. So this paper just looked at the utility of using an MPO immunostain, which we did not have in this case, in a lot of these different crescentic lesions with background mesangial and a PR3 crescents, the classic POSSE immune glomerulonephritis, endocarditis associated, and they also had some membranous with crescents too in there. And the use of the MPO immunostain was helpful at differentiating some of these, not all of them, but the MPO immunostain, even actually in PR3 vasculitis, was sometimes positive, but the MPO immunostain was positive in their membranous cohorts, but it was also positive in hydralazine associated and in the MPO crescentic GN with mesangial deposits. Okay, Most of the time it was negative in endocarditis. So I'm not sure it really would have helped us here because we were still trying to differentiate levamisole versus actual endocarditis. You could argue that the biopsy itself wasn't helpful. It was the culture results that gave us the answer here, which again, very likely we wish that were done in 2023. But at least there's some times where you can use some of these things to try to help you figure out which one's which. So this is a case series from a lot of famous nephrologists. Okay, we've got Dr. Kauser on there, we've got Arcana on there, and from the Mayo Clinic. So they're pooling together all of their patients, and you can see the N is not very big. Okay, it's not a very large amount of patients, and this is from 3 very large institutions, but that's what we have. This is an update on what glomerular nephritis in the setting of endocarditis may look like, and there's some patterns here that aren't that surprising because we already talked about them. Hypocomplementemia is common. Crescentic injury does not have to be seen all the time, but in 53%. Okay, some of them just have a mesangial pattern of injury, mesangial proliferative, and here's the immunofluorescence, which we had talked about. Some are negative, but there are some that are some are negative, but some the most common one is mesangial background alone. Okay, so in our first case, we had this crescentic GN mesangial background alone, and in the first biopsy. Okay, and there's the classic staph and strep, but then there's the fastidious organisms that we discussed in a variety of different percentages. And so let me just kind of show you, because I think this in this paper, this looks a lot like our first biopsy, right? We had a crescentic GN, okay? But this looks a lot like our second biopsy. Continued immune complex deposition. Again, we only had 1 glom, so it's very possible that there are a whole bunch of other ones also there with crescents. Okay, but we have this continued immune complex, which might have been exacerbated by his use of rituximab. Certainly he was immunosuppressed, and he had a CD19 count of 0. And so this background C3 deposition is common, and here's the electron microscopy. But what about the TMA? TMA, a lot of people picked as part of this process. The TMA was tricky. Even hematology was a little perplexed. At first, it makes sense that it would be from almost the Waring blender syndrome that Dr. Shielvant and I published on a little bit ago of from the valve itself causing a shearing. That was a possibility, but it didn't improve. It started after he got rituximab, and it didn't improve after they replaced his valve. If anything, his hemoglobin stayed at 70. He was still actively hemolyzing. The next thing, of course, could be immune mediated, but his Coombs test was negative. So I looked up how often Bartonella gives you a thrombotic microangiopathy, and there's a lot of animal models showing that that it can happen through direct endothelial cell toxicity. And then I found this case report series here of it happening in immunosuppressed patients, those patients that were transplanted having Bartonella injury and giving a TMA, and this happened independent of CNI use. So there's some patients in this series that weren't on tacrolimus or cyclosporin, because those would be obvious other culprits when thinking about thrombotic microangiopathy.
Bill, this patient really, we didn't see a TMA, but what we saw was microangiopathic hemolytic anemia.
Yeah, that's right. We didn't see a thrombus, but you don't have to have what's termed TMA. Do I think there was, thrombi there? I mean, he has renal failure that's still unexplained.
Yeah.
May I interject?
Was that due to TMA or was that due to a vasculitis? And yes, Dr. Rubin?
The double contour can be a manifestation of TMA.
Chronic TMA,
Yes.
yeah, good point.
So unfortunately, you did not have electron microscopy, because if you would have seen the reduplication plus this flocculent subendothelial material, then you would have said, bingo, TMA. But
Yeah, that's
you
right.
didn't have it. You didn't have it.
I mean, your classic non-immune TMA has this MPGN pattern of injury and it's negative immunofluorescence. We think
What you didn't see
that's right.
were red cell fragments on the light microscopy of that glomerulus, which would have favored an acute TMA. But the finding of reduplication might be consistent with the chronic TMA. Who knows how long this process could have been going on for quite a while.
Yeah, and this sort of fits that it might have been Bartonella there the whole time. And now the TMA is more manifest because he was immunosuppressed with Rituxan, right? And even his valve replacement, which was 5 years after his initial valve, when we talked to cardiology to say what happened back then, 3 to 4 months ago, they don't know. They don't, and this is a very unusual pattern for someone to have valve basically disintegration without, at 5 years after that major surgery. So to me, it makes much more sense that, as some of the people in our wonderful audience kind of guessed, that he's probably had Bartonella the entire time.
Entire 5 years?
5 years, causing his initial endocarditis, replacement, his initial ankylosing with the background mesangial deposits, then immunosuppressed, then the TMA came out even further. The TMA did not go away after valve replacement. It doesn't look like it's the Waring-Blender syndrome. It all sort of fits that it's just a very long course for Bartonella. And when this came back, I went back and asked ID that, and they concurred. So
that's got to be the, I haven't searched this, but that has to be the longest Bartonella.
Yeah,
5 years is absolutely incredible. I'm not doubting you for a second. It's logical. It's very logical that that's what's been going on all along. It's such a slow kind of organism. You'd think, in the end, endocarditis, is an immune complex related GN, and it's post-immune. His second one was immune complex. Let's put it that way. Yeah. And you'd think the rituximab would have kind of, his CD19 was 0. You think that would have somehow suppressed it, but obviously it didn't.
I think I would have to endorse what Bill says and point out the fact that in the initial evaluation, it was incomplete. Yep. No rheumatoid factor, no evaluation for blood culture negative endocarditis, and the immediate treatment with rituximab. This is kind of using a reflex of, you see crescents, we use rituximab. That's not a good idea. You've got to be sure that the patient does not have an underlying infections, and blood cultures and TE are not enough.
And his valve replacement, might have been accelerated. Then the need for valve replacement and valve disintegration might have really been accelerated by this immunosuppression on top of this fastidious organism.
Well, it's amazing he didn't do worse, is what I think, Dick's point is that you don't want to immunosuppress someone with a chronic infection, and they very immunosuppressed him.
And no one still thought about when they did the valve replacement. They just replaced the valve and then moved on. It would have been great to get valve tissue at that time.
There was no rheumatoid factor, and we weren't, it wasn't like there was one and we were keeping it from you guys. There was never done. And remember, this came from another institution, so we're not trying to throw anybody under the bus. We're just saying that, we didn't miss it. Hopefully we wouldn't have missed it. And we didn't miss it this time. Bill and Prevere didn't miss it this time.
In summary, I'm not sure that the illicit substance use and levamisole and cocaine was really relevant at all. He was labeled that. He was never tested positive. When you really asked him about the history, he really wasn't using cocaine that much, and he had stopped it, for a long time. But there's not a really good history of a cat scratch either. Sometimes people just have it even without the history. And that was another reason to have ID, because they take incredible histories and they still couldn't figure out where it was coming from. So what did we do? Obviously we stopped his rituximab, but that's going to take some time to wear off. For his blood culture negative endocarditis, quote unquote endocarditis, which is still what I'm calling him. He got ceftriaxone first, then doxycycline. And what happened? He defervesced. He got off dialysis. His creatinine stabilized around 2.5. His complements normalized. He still's got some hematuria and proteinuria. His hemoglobin, of course, he had some transfusions, but then it all stabilized like at 8 when he left the hospital. Now it's 10 to 11. His platelets have come up to 150s. His LDH has improved. Now his haptoglobin remains undetectable, but this is a protein that takes a long time to recover. So far, just with the antibiotics alone, he's kind of doing pretty well.
And you wonder if this would have been picked up initially, you know, as suggested as it should have been. I mean, a drug abuser with valve disease, you got to absolutely make sure. But I think, you know, you're right, Bill. They just got thrown off by the PR3 and the levamisole story. It's just, it was so, and actually that was a few years ago. That's when levamisole was really a hot topic.
I think that actually was around 2015, the hot topic. And also,
really?
classically, with these really bad, debilitating, necrotic skin rash lesions of your face and all this stuff. So it didn't quite classically fit, but, you know.
You're right, Bill. I forgot about that. Yeah, at least the ones that are in the literature, they've got, you know, a black necrotizing ear or nose or something.
But
Yeah.
I can't quite fault them, because remember that sort of that pattern of injury that I showed. The immune complex background with the crescentic can be levamisole. That's what is described, just like it can be Bartonella. So, you know, but before you're immunosuppressing somebody, I think it's a really good idea to get these fastidious cultures sent off.
Yeah.
You know, last week there was the lesson to always get. Last week there was.
In retrospect, Roger, the biopsy was misleading.
Right.
And actually contributed to a misdiagnosis and probably erroneous therapy. So the biopsy in this case was not helpful at all, perhaps maybe even harmful. That may be an overstatement, but
Well, I don't know about. I don't know.
To
I think it was
emphasize Bill's point, the biopsy is so non-diagnostic that it can hardly be used to make a decision about treatment.
I had actually sent off the Bartonella before we got the biopsy in this case.
Yeah.
But the problem is that it takes 4 weeks for it to come back. So then we knew when we saw the immune complexes on the second biopsy, we really needed to start some therapy empirically before we were even waiting for the results of the Bartonella. So I mean, I was using the biopsy to sort of speed up my workup because it takes so long. But then again, remember, biopsies are not benign, and this person did have a pretty complicated one. Quickly in the chat, somebody asked about complement levels. If you go back to that Boyle's paper, I think they wrote the percentage of hypocomplementemia in one more. Yeah, so low C3, C4. There's your percentage in endocarditis associated GN. So it doesn't always have to be hypocomplementemic, but it makes you certainly think about it when it is.
Yeah, and I think that the point here is that the infection-related GN, to use the more proper term, has many faces pathologically, has many faces clinically, has many faces serologically. And so you have to be careful, and you can't just jump on a bad GN and assume that it's not. And the more information you have, last week, you know, I learned that we should probably, we should always get an anti-GBM antibody. You know, I took it too lightly, that you can't afford to be wrong on that. I think the lesson here is you should always get a rheumatoid factor, because, you know, it's as non-specific as that is, it could be a very sensitive test for an infection-related glomerulonephritis. Dick, if we knew that the patient had a rheumatoid factor the first time around, and it were normal, would that dissuade you from an infectious-related GN a lot or little?
Yeah.
No, it's a question, Dick. Would it have, if the rheumatoid factor were negative in the first biopsy, would that have changed your opinion on this, the high likelihood of this being an infectious related GN?
I don't think so. I think the biopsy can do anything.
Yeah.
I don't put
Biopsy-
much reliance on a kidney biopsy in a setting like this to guide treatment.
Well, that's what I'm saying. The biopsy, the serologies, and the clinical presentation. You just can't afford to be wrong. And
Right.
if there's anything here, it's the original story. This guy's IV drug, drug abuse, and so, you know, you have to think about that. And it has obviously huge implications, as you can see. And I think Dick's right. Whether the biopsy fooled us or whatever fooled us, and this guy got 2 years of treatment when he was brewing an infection. I think he's lucky to be alive, and he's lucky to be off dialysis, quite frankly. So the amazing part is he did clean up his life, and he's not taking drugs. That's probably more remarkable than anything. Not to be such a cynic, but that being the case. Any other questions? Any other comments? Let me ask real quickly, has anybody seen a case where they thought Bartonella was brewing for 5 years? Dick, you've seen a lot. Have you ever seen anything that's brewed for 5 years?
No, not 5 years.
I think it makes sense though. I buy it. I like it. I buy it.
We'll see if he
Mario?
continues to do well on antibiotics. He's doing pretty well so far.
Mario, Rune, Dr. Reen, anybody seen 5 years of?
Not me.
Yeah, well, I like it. I like it. I like that. I like the story. It's a great story, and I think it's very parsimonious. Occam would, I think, like it. With that, we'll move on. Thank you very much, everybody. We're not sure if we'll be on next week or not.